Uh-huh. I was at 6. Yeah. That's one. No, he got us. Yes, yes. So yeah, I was gonna text you last night. 22nd.
That's all I know.
No. He literally made that clear. It's like, I'm not going. Like, I'm not asking you to go. Like, I'm just saying. Aww. You've been so good to me.
That was fun.
I haven't looked at it yet.
Spiritual experience, this is so deep.
Totally right. Congratulations. How's it?
There is like no rhyme or reason why things happen like that, right? You just have to like memorize it, but there's no like
It's where the receptors are
thinking
located.
about it, right?
Yeah. Well, I mean, the way you think about it is
One is opposite of the other.
like fight or flight. So like in the video, they were saying, these are all the things you want if you're being attacked or you're running away as a primitive woman. And this is the balancer to that. This is sort of a kind of keeping it in check.
This one is the balance.
The alpha 2 is the balance to alpha 1. The other ones, yeah, I got no explanation.
I think too, then that one would be rest and digest, right?
No, it'll be we'll do the parasympathetic nervous system over on that side.
Okay, so
This is
of
all the
Okay.
sympathetic nervous system.
those. Right up there.
Yep.
Yeah.
The adrenergic neurotransmitters. You can remember adrenergic because sympathetic involves the adrenal gland. So adrenergic. So when you see adrenergic, you'll think, well, which system had the adrenal gland in it? Oh, it was the sympathetic nervous system. That's the part we're talking about.
Let's go with you. You kind of rushed through.
That's how it is.
You rushed through that in anatomy at the end because there was just so much to cover.
There is. That's how it is. And really the onus is on everyone to take half an hour, watch a video, take notes. Like I printed up these. This is autonomic nervous system, sympathetic division. This is parasympathetic division. And you're welcome to kind of take notes on what happens in each one. Sometimes writing helps you remember, and then you have a worksheet to look at.
Right.
So all, you're welcome to, just trying to give you as many tools as possible. 'Cause there's a lot. This is a huge component, like these drugs come up many times and we'll say, remember when we talked about catecholamines? And we'll be like, no. Remember when we talked about alpha-1 adrenergic drugs? Because they come up again in another place when we talk about another topic of treatment. If we're treating, if we go to the respiratory meds, because there's a chapter on that, then we'll come back to beta 2, and we'll be saying, remember when we talked about beta 2 adrenergic drugs? And you're like, no, but if you have something to look back on, like a handout or a worksheet, it'll be easier to kind of just refresh. If you have something to look at, it helps you focus on what we're talking about, where it fits in. Otherwise, it's just pieces floating around and words and adrenergic, cholinergic,
Just need to anchor.
norepinephrine, noradrenaline.
I'm just hoping that all the little pieces will just come in like.
No, it's going to get more complicated.
They like you to say that.
That's very encouraging.
Yeah, prepare yourself now. So, yeah. It just doesn't get any simpler. And this is like making it as simple as we possibly can, just to get concepts and why drugs work. Because if you know why drugs work, it's easier to remember them. That's why we go over this. We could just say, oh, all these drugs do this. But it's better if you have a concept and you can go back, and then you understand why the adverse effects happen. Because you know the physiology of it. Theoretically. Anyway. Cheyenne! You're such a quiet guy, I have to like, one of these days I'll hear you say a whole sentence and I will be over the moon. Excited he looks like. All right. Absolutely. That's kind of just take and use it as you as a helpful study tool to take notes while we go through stuff.
Color. You splurged.
I didn't. I printed to mail at front desk to print yesterday, and I came in and it was printed in color.
Wow.
Like, whoa, you broke out the big box. I should have made it bigger then. Didn't know she was gonna do that.
She must like you.
I don't know. I need to bring her a prize. Prize. Hey. I have your prize for your blackout. What? Thought to do better to be prepared. I didn't even think about the blackout, so left it home. You know, you never get enough prizes.
That was very sweet.
Well, I don't know what's in there.
Just
It's like garbage or something, you know?
It's a cute bag though.
Yeah, it is.
Sometimes that's all that matters.
All the time it is. See that? Or else. In the know now.
No, it's like, they actually didn't help me at all.
No, it doesn't help you if you have too much information.
Yeah.
Yeah, I feel like $30.
Hey, all right.
It's like you got me right. Just wanna make sure.
Uh,
1 minute ago.
All right.
I was here on time.
I gotcha. Getting people, are you here on time?
I technically was. It just
I
takes
know
me
that you
5
have a
minutes
little
to
bit
get
of a
upstairs.
mobility issue, right?
Yeah, it takes me about 500 years to get upstairs.
Is that all?
No, I had Quizlets.
So you told me so.
Yeah, so 35 minutes per year. I mean, really, I was- Yeah, it just gives you all of this extra. I really liked it. It's on my Instagram.
Or doing the.
No, it's just on, yeah, it's just on campus. Make it easy for ourselves.
How was life?
Did anybody tell you what she was? Oh, she sent it out. She said to let me wait a little bit.
Do you work?
Not right now. No.
That's good. I know, right?
Alright. Right back.
Aww.
She
I probably still feel like, look who I
Is she? Yeah, because she was here yesterday for lab and sit, and she was small. So she.
Well, that's Marissa.
Okay.
There you are. Let's see. Oh, it's not here. Let's see. Yeah. And Amber, you're the correct, right? Yep. Amber's the correct.
Only for another week though. 6 more days of crutches.
I didn't call your name because I think I know who you are and I marked you here.
Thank you. We don't know.
It's possible. I mean, I could be wrong.
Oh. I'm like, I don't ever know anybody's names. I really know my kids' names.
It's, I'm telling you. I got cousins, uncles, like.
This number's today. It's like they're only here for 12 weeks. I mean, yeah, you've learned a lot of them, but not of them is exactly.
All right, so with the math quiz, just pull it up on Canvas. And they all should be in, you should be able to see it all at one time. I didn't bring up calculators, but you can use your phone. If you need a calculator, I can go down and get them. I think we have paper here somewhere. Here's some like scratch paper you can write on the back of. And then you can work in pairs, just kind of work your way through this. Yeah. And there's no time limit. So, Go ahead and start, choose your partner and have fun. Read what the question's asking. Don't assume it says milliliters, it says liters. Liters might say pounds. Yeah. Oh, wait. We have lots of power cords.
I just have to work with Wendy too, but it's okay.
We've got more students partner.
I was gonna say that.
You say two?
Hi,
What the
man.
heck? Yeah, you can use calculators and your computer calculator, your cell phone calculator. They're all good. Working alone, so if this one works for days. Oh, gosh. And you might, if you're gonna reconsider your answers, well, I don't think you have to submit them one by one, right? It's all the way at the end. Okay, yeah. Try to make it user friendly. Smart enough. Yeah, fair. Marissa, you can log into the computer and go to Canvas. You can either do it by yourself, or if you want to, video into somebody's group, that's fine too. You don't have to do it by yourself. What would you like to do?
20.
I'm just gonna kill out.
I'll be a little bit. Yeah.
Longevity is Carol Fee. Some produce. Oh, yeah.
Oh. Thank you. Hey, Alex.
Welcome. Yeah, CC is the same, but CC is gone out of cash.
Right. Like asking a lot of questions. Red blood cells count as output or input?
There's volume, yeah.
Okay, that was an injection.
Oh, yeah. They're giving you the volume for it. I mean, if they had said like an avocado. That's not it.
Red blood cells count.
Thank you.
Just kidding.
Did you just put that up there?
So it's after you ask the question, I figured somebody else would have the question, so.
Yeah. Yeah, and that's what so I got 500, 50, 10, 120.
I did this and this.
Oh.
I'm glad you didn't mention it.
Yeah.
Yes.
Yeah. Yes.
Oh, shows the opportunity to. Yes.
Oh, wait. Okay. So what?
Yeah, it's. So let's see, we went over the 15.
Yeah. Yes.
Yeah.
Hey. Sorry, I'm late. Can I get a- is it a mouse? It's online.
Oh, is it? No, it
We
isn't.
have fun.
Right.
Maybe that's what
We have done this very well.
Not enough caffeine.
I know.
Especially that clinic was yesterday. It's hard. Well, we have to wake up to lift our, I live at 3:30. That night.
Rápido. Líquido. Esse método, okay.
I didn't even.
You're not supposed to do this. But you see, I'm not waiting to go get some water. I'm not listening. Carbidopa.
It's like the mom and us, we're always.
Yeah, we have like eyes in the back.
Oh, yeah.
Right. 2 years after year.
My daughter.
Thank you. I'm really too embarrassed. Thank you. For correcting. So. Because
Yeah. Luckily, this is like I said, we try to live it up.
yeah, they don't say carbidopa. This is what you
It is 1.75 per
I have a question. So for the intake and outlet, that's how you want the answer.
Yeah, just a slash. Okay, yeah,
And you put intake first, right?
yeah,
And then the outlet.
yeah. And I'll go through afterwards if there's anything that's missed because
So the mouth part. Yeah.
Yeah.
Okay, good. It's 7.5 per kilogram. Okay. It's 75. Yeah. Because the dosage is I was like, I have to skip it. I mean, because
Are you done?
Yeah.
Okay, can I compare my answer? Yeah, I don't know. Like, wait.
Oh, yeah, so the idea, yeah, so for that's okay. On the freaking more people, I was like 404, so it's like.
Yeah.
Because 5 grams was one in one day, you do 4 or 5.
I did that different. I did like the hours a week. But I didn't get 7. Sheesh.
So it's this whole.
I added it up. So input there, so the first one, because it's a whole lot. So the first one is 6. The first one's 500.
Wow, 5.
I know.
But that was only 10 hours. So it's 8 to 6. Yes. That's what I got.
So now.
Yeah, I took it. So you got 27.
Yeah.
Okay, and then five.
Yeah. Which one? Yeah.
And then eight, I got.
Yeah, but there's. And it's counted. Yeah, so I did that. So then that's what I'm doing. And you times that by 1.75.
Yeah.
But it's for cheap, you know, there's we broke it down to one.
Oh, okay.
Because I don't have it.
We're doing it.
And then you divide it by your half, which is 500. Yeah.
So why do you have to divide by 500?
Because that's how many milligrams are.
Oh, I see. So then that would be 0.5.
Hey, Kayla, we got number 8. Number 7. And then 28. But that's a good one.
No, I don't think that. That's what from my
I could very well be wrong. There's just a lot of stuff. Or maybe it's. Yes, no, that's why it's like. Okay. I see. I got 1.6. So you just got it. No, 6. I got 1. Yeah. So it's 81 ounces. I mean, Kayla, the 1.1 is actually 2.2 because you take the rest of the other one. Yeah. I got 1.6 on it, so I don't.
Yeah.
Okay, 350 milligrams. And there's I got 0. You got 325, right? Maybe 75 kilograms. Oh, It says every 12 hours, and then we need the total daily. Oh, well. I don't. And then number 3, I got 7.
No.
Does that make sense? Yeah, so it's 7 ml, right? You can take 20. And that's it. For which window? Wait, I wanna add that. I got one. We have you know, this rotator come better is like which one?
And then available is 10, so.
It says twice a day, but they're only wanting for one dose.
So we can.
Yeah, so on the, when it's in the question, it says how many times you can answer.
We just have a question on this one.
That's all we got. But we asked them up so many times, we got one out. Is 2,400.
Are you guys on number?
Like we added it so many times.
To be.
For the course? I didn't get 1,900, yeah. Because this one is 500 and the 50 and the 250, 20. Yeah, that's why 500. And the 20 and the 50 and the 10. Yeah, this is. But it all adds up to 150. I know, I like that. She's gonna check it. For the second, for the out.
Either by cash.
You still want to explain it?
So I'm like, where is it sent it to?
My plan is always to go through it.
Yeah. Okay. Yeah. Like, sorry, but the- so we're good. So that one was worth it. Yeah.
The only other one is. It says baby, and then very, in the explanation.
Oh, what the heck? Okay, I'll go ask her. Yeah. Can I bug you again?
Right, two. The apprehensive, when you went through the explanation. So I don't know what we want.
No, I should.
No, it's a lot.
Why?
And that was
The only other one that was worth
Remember whenever I want.
Yeah.
There's that 6 that we have. I changed it from a different question to different numbers, so I wonder if I.
How many
Because
Oh, she said you could.
it's one of those.
Okay, so you got the tip.
Yeah.
So which one?
But then she's doing like transfer.
Oh, yeah.
But she said what is number 8, that's only one talk. Yeah. Well, look. You what?
I had some circle that I didn't do it.
No, because I remember.
How's you doing? The kid?
Oh, yeah. And then you try to finish this.
I had a circle. I had a circle that I needed to take a six, and then I brought it back to the nine.
Oh, you did good. And you. I didn't know. If she doesn't. I would finish.
Did you look to see what's in your bag? You guys can fly. Oh, no, don't do that.
I will do it.
We are 1.6.
So number 7 is.
Because I've been eating too much.
Yeah, so.
I can't go there to tell her because literally that's the answer. So you go back. Yeah, did you? Yeah. Okay, so I was like, since you moved out, because I'm like, because the design over half of everything else, right? Would be the
No, you're right. I
269.5.
just had taken the answer from my old.
No, I know, but I'm just making sure I did the math right.
Well, it's got the
Like
right
the
answer.
right thing. 269.5 divided by 500 is like 1 point something, and times it by the 2 because it's per 2 mil. Then times by 2 because they get 12 hours.
It's not times by 2,000. It was step before we had made it 1. That's what I thought. Okay, I ready? Megan. This is. No. It's still. So we had changed it for 500.
Oh, I didn't know.
So 1.5 milligrams.
That's usually really complicated.
You know, this is just, there's one way.
Yeah, that's why I was like,
You could have left it in 2 and then this just. Yeah. And then divided by 2. So, yeah, and I'm going to say 1, 2, 3, 4, 5, 6, 7, 8. Yeah, but I've updated the answer.
Yeah, number 8. Yeah, it's 2.2. But they say that it's lottery and then they'll give you mass that is correct. And then it's either that is asking you how to do it. That was the only one that told me. Yeah. And so I got 100%. Yeah. No, yeah, and then. Yeah. So I mean, but it's gonna say that the.
Yeah, so no, I changed the answer, so it shouldn't say it's wrong now.
Yeah, how is your little one?
So maybe I didn't change because I've done it after. Yeah. Yeah, no.
You crushed it. Thanks, love.
Thank you.
I have a question.
Yeah.
For the last one?
Yeah. I know, it's, yeah, I went in, I'm going in.
Okay.
Points in.
Thank you.
I'll double check everything.
Oh, that was like so. I think this science section was 10. And so what happened was
I need more.
so it's like she'll be here like so she gets there like 1:10. They said that the answer is after.
But yeah.
Either way, like it's fine.
Yeah.
As long as I can make it up.
We literally sat there for so long.
I know, and I'm like, and they're always like to run anyway, so we didn't even get in there until like 1:06. Whatever. There's like, there was like hips, but it wasn't just that. So like, oh, like lands and strong. They were all like this one.
So how many hours here?
Yeah.
I mean, that's 6 hours.
It was just like, I didn't like,
Or no,
they
no,
like
no.
all this went over that. Like it's 10 hours.
10 hours, yeah.
What the hell are you? Like, how much
Oh, okay, now I see
I
where.
don't know that.
You gotta calculate it 10.
Yeah, so these are rates. And the rate here is related.
So, yeah, this one would be 120, right? That would be 100. And then those are individual, that's right, that's right. That is right.
Yeah.
We'll go back and think that.
It's like, who is it at least?
All right, Ferguson. What are we sharing today? Oh, oh, they're colorful. That's fun.
Thank you.
It's a beautiful day to save lives.
Aw.
Smack me in the face.
Just make it don't feel so.
How fun.
I don't like what work there, but I'm super good at that. I don't like it.
I know.
Have you ever heard of Pharm?
The problem is like, they didn't do the math.
Yeah. Billy Sykes.
But because of your profession, you should know.
Yeah.
You should find out. That's like, we were, there's such a.
But it's,
We never know.
It never is.
so I did, obviously, I did the counts, 2 kilograms, which was. And then, the baby.
Oh, that's a picture.
So I broke it. And so I went 1.7 miles. And then divided it by. Yeah. Yeah, and a lot of it's about like mind. Yeah.
I'm sure he would have done.
Oh, he would have.
I'm not going to be doing this. So I'll just keep doing.
You will be like a familiar.
Hi.
Thank you. I get so tired of having to fill that.
He's the most mobile, like they feel the same. And watch out with the water. You asked for a price. Like my little things I put in I use it. No, I understand. Did you guys do anything special?
Really?
Yeah, usually we just.
Did you go?
There's so many different answers that I don't get. Oh, okay, so it is, oh, okay.
Yeah.
Okay, I have a hard time with math, so I was like.
No, I don't even know.
But yeah, you're gonna be 17, you say, oh my God, it is still young. I think that. So next week. With your respect.
Courtney, did you submit yours?
Yeah, I just did.
Oh, okay.
Okay, so then with this number four,
Yeah. It's also 20.
yeah,
Oh, okay, so I still would have gotten it
Yeah.
wrong.
Yeah.
Okay. So are we sleep?
I took over how to do it. Clearly I overthought it.
No, I mean,
Because I got
close.
25 and I ate.
So we've got. No, it's not 12 hours.
He had all it on my library, it was on my first bag. So I like put it all.
Because it says per hour, so then it says 12 hours here.
I forgot to look at the time. I it just
Yeah.
went into my mind, like 12
Yeah.
hour shift.
That's
So
how
I
it
just
is this, but this one applies to that. Because the fee is not, it's gonna be given over a specific time period.
Oh,
Yeah. That's like,
little thing.
no. Oh, things are. Anybody else still working on it? Justin, are you still working on it? No? Here we go get some ice. Yes, you can do anything you want.
So don't start talking.
I'm fixing the scores because question 4 and question something. Everybody submitted? Okay, no worries. Cynthia not submitted yet? Cynthia. Oh, maybe. Check my roll up is here, not here. So I got 5 weeks. It was like I didn't have any- maximum of 5 weeks, and I had But you would speak to 5 weeks old. And so let's start with
Bye, Sally.
Do I leave it in the classroom or should I leave it in the drawer?
I don't know.
Because I remember grabbing it. Better grab it.
Like when they came back from conference.
Oh, but there is a retard. So.
Like that, yeah.
Okay, cool, thanks for the tips. Sorry, no bathroom allowed. Everybody's score should be updated. So there was an issue with question 4. So. Half on the. See if we can walk through it. So you have a 12-hour shift. The first one is your jeopardy. How long is that shift? Do you remember it was 8 p.m. to 6 a.m. So 10 hours at 50 mils an hour is how much? 500. Okay, then we had 50 cc's of free water, which is ml. Okay, then we had 250 ml of red blood cells, which is. Then we had 20 cc saline flush. Then we had 15 mils of Zosyn. Then we had 10 cc saline flush again. Now, you've got heparin and NS. Over your 12-hour shift, you had heparin at 10 mils an hour, which is 120.
Yes, explain this.
And then 100 mils an hour for 12 hours. 1200. Is that how everybody did it?
Yeah.
So 5, 10. Yeah. It's 2450. So if you wrote 2400 on the answer and it marked it correct, I had to go through and take off 3 points because it's not correct. The answer is 2450. The other one that we were having issues with is that the one with the calculation of streptomycin in pounds, and then the patient weighed kilograms. I put, the answer is 2.2, and I was putting an answer from an old exam that was 1.8. So if you marked 1.8, I had to take 3 points off. If you marked 2.2, I put 3 points on. So the grades are accurate as of now. Let's see. You did something or other.
Oh, that's my computer's just being done when you did update it. Let me just exit out everything. Just finish.
Okay, let me go.
I'm not looking for you to chase through anything, but.
No, I want you to
I knew all the kids.
fight for your points, because I would.
When it's exams. So like, no, if it was homework, I'd be like, whatever.
Let's see what happened. So.
Did you refresh?
Yes. For you. I gave you credit off of this one.
Thank
so
you.
that's
Thank you.
plus 280. And then I gave you 3 more on that one.
I just say. My name. Kathy can.
Oh, it says 15 now.
It is.
Yeah, my refresh button.
There we go. Okay, cool.
Yeah. So that was the main issue, is that putting 2 wrong answers, and if you happen to take answers from somebody else and put them in because you thought they were right, then you were screwed. That's right. Do your own homework. So yeah, 2450, and then the other one was 2.2, not 1.8. And then the rest of them, if you got them wrong, if on the one at the very last one, if you put a comma in it, it marked it wrong on the total intake of fluids. Question 10 is 2,430. If you put a comma in, I went back in and gave you the 2 points for it because it marked it wrong with a comma. But that's okay.
Do we ever want to put a comma though? Because this end up sometimes with like a period and then it said like.
Well, I mean, in this case, we're just.
Well, I know on this, but like, in like, when you're like, say, working in numbers, if you put a comma on.
Well, if you put a comma, there's gonna be 3 digits after it.
Like I said.
I don't know. I mean, that's why I don't know that there's a rule about commas.
Oh.
All right, so everyone's had a break and a chance to go to the bathroom and all of that.
Oh, no, I was. She was like.
Service hours.
I'll be right back.
I'll let you know what it is.
Okay, sounds good.
Sorry for-
This quarter was so like. Yeah. The clinical agent is just being seated. They say this is one of the hardest ones. I like that analogy. 'Cause that's
I'm just trying to catch some of it. Things that you were writing.
About the credit policy, yeah, just because I was like,
she's gonna explain.
where did we leave off last time? Anybody have any idea? I'm not quite sure where we left off.
We finished drug abuse and we were starting the next one.
Well, I know that we had seen some of the neurotransmitters because we had started writing them.
Oh, yes.
I had written them on the board, but I wasn't sure exactly how far we got into chapter 18.
I think we finished at targets of adrenergic drugs.
Like these are the targets. That's how far we got. Right. Okay. Is everybody like super confused or you get it? Like this should be your second time at least talking about the sympathetic nervous system, right? And the neurotransmitters and, you know, where they're generally located and what triggering them does. So having an adrenergic action is just promoting this particular action. And it's a lot to kind of put in your head. These effects are kind of weak, so we don't really think about too many drugs for it. These are quite strong. And remember, drugs that hit a receptor are not necessarily discrete. They don't, if we say it's an alpha-1 adrenergic agonist, that really doesn't mean that it only hits alpha-1. It's just mostly. None of the drugs are like black and white. None of the receptors are black and white. There's always some crossover. So that's why we have some of the side effects and some of the crossover onto another receptor might give us unwanted side effects. All right, let's look at, let's see where we are. Open. Sorry. That was just to wake you up.
We need it.
I know.
It's good.
Yeah.
So did we look at this already? Yeah. Your norepinephrine, your epinephrine.
We don't need caffeine today. Yes, we do.
So I know we talked about that. And then we talked about the drugs, right? Afrin and phenylephrine. And yeah, because we talked about rebound congestion, alpha-2. I said that sort of the feedback loop to alpha-1 to try and kind of keep it under control. And then beta-1, let's see if this one has any information for us. See if I can. Hopefully everybody watched my video link because I really enjoy it. It's a wonderful video link. Let's see. Yeah. Plus, these computers are so horrible. Baby.
Now, let's start with beta-1 receptors.
Yeah, we did. I think we did.
Beta-1
this.
receptors are mainly located on the heart.
Mainly on
And
the
when
heart.
activated, they lead to increased heart rate, increased cardiac contractility, and increased AV node conduction. Beta-1 receptors are
That's
also
these
located on the
three.
juxtaglomerular cells in the kidney. And when activated there, they lead to increased renin release, which results in increase in blood pressure. Now, let's start with beta-1 receptors. Beta-1 receptors are
that is
mainly
beta-1.
located on the heart.
Oh, wow,
And
it's just
activate-
repeating itself. Okay, we did beta 1. I remember that. Let's see if I can, yeah.
So these three, and I had said you should know these terms. So chronotrope is talking to how fast your heart rate is going. So if something is a positive chronotrope, it increases your heart rate. Negative, it slows it. And there's times that we want to slow it, not just tachycardia, but also if we need to allow time, well, it could be tachycardia, for the heart chambers to fill, then we may slow the heart rate by using a negative chronotrope. Inotrope is the force of the contraction. If you have a really weak and damaged heart muscle, you may need a drug that's going to push blood flow forward. Dromotrope is the conduction through the electrical conduction of the heart. So those are the ways that we play with the heart function using beta-1 adrenergic agonists, right? Now, I think, did we say beta-2? Maybe we'll. I don't know why my little video link is not showing up on this guy. This is really annoying. So I don't like to wait.
Beta-2 receptors are mainly located in the lungs on the bronchial smooth muscle. And when activated, they lead to bronchodilation. They are also located on the vascular smooth muscle and the arteries of skeletal muscle. And when activated, they lead to relaxation of blood vessel, or in other words, vasodilation. They are also located on smooth muscle in the GI tract and uterus. And when activated there, they lead to smooth muscle relaxation, which in GI results in decreased motility, and in the uterus, it can cause inhibition of labor. Lastly, beta-2 receptors can be found in pancreas, and when activated there, they lead to increase in insulin secretion. Beta-2 receptors are mainly located in the lungs on the
All right,
bronchial
we got
smooth
it,
muscle,
buddy.
and when activated, they lead to
Back.
bronchodilation.
All right, so those are the actions of that. So that's why we are going to choose targets. Slideshow. It's getting all whacked out here. There it is. All right, so just a summary of exactly what he said. So when we stimulate it, we're going to get relaxation of the bronchi, well, the vascular smooth muscle around the bronchi. So our lungs open up, our bowels slow down, however, and our pancreas secretes more insulin. You just have to learn them. Beta-3 really has minimal uses. We just use it in bladder spasms, and that's here to relax a specific muscle in the bladder to allow the bladder to fill up more completely, and use it in overactive bladder for bladder spasms. And there are actually, I think there's a newer drug, there's 2 drugs on the market for that. And then in general, dopamine. Dopamine is used for vasodilation, and in these specific areas, it's a pretty massive vasodilator. And so if we do something that would block dopamine, then we would end up super vasoconstricting. If we use dopamine itself, then we're getting a whole lot of vasodilation. It's just a matter of learning it, and there's not a whole lot I can do to make you learn it other than you just practice it over and over. All right, I guess we don't get to see that one. Too bad. So sad. Dr. Mike is cool. I like him. He goes through it great. All right, so now we're going to go to the drugs. All right. That's the good part where now you know the background, which kind of looks like a crossword puzzle. We talked about a catecholamine. That term comes up, and it's just, we learned the vocabulary of medicine. A catecholamine is any of the neurotransmitters that mimic the sympathetic nervous system. These are the ones that our bodies produce. These are some that we make in the drug factory. And then these particular medicines or neurotransmitters get broken down by the enzymes you've seen before. They're broken down by MAO and COMT. So already you can see that if we could play around with the enzyme that breaks them down, that will be a target of some of the drugs. So maybe we'll give the actual neurotransmitter, but maybe we want that neurotransmitter to last longer in the system. So we'll monkey around with the enzymes that break it down and maybe inhibit them so the drug lasts longer. We're pretty clever in coming up with ways to play with the whole system. We do want to know about the drugs that are specifically acting on the vasculature of our bodies, because there's a lot of them and you'll see them in the hospital, especially if you work in ER or ICU or you're on crash cart. I mean, it's part of your ACLS certification. You have to know these drugs. So they're called, there's also two synonyms, vasoactive adrenergic agonists or cardioselective sympathomimetics. It all means the same thing. They are drugs that act on the adrenergic system, and they are more focused on the cardiac receptors. So we use them in life support for shock or cardiac failure, and depending on which drug, that will determine which receptor they act on. So let's talk about some of these vasoactive. So epinephrine is non-selective, meaning it doesn't specify alpha or beta. It's going to hit a lot of the receptors. It acts on both alpha and beta, which means that it's really, you get a lot of bang for the buck. What we're trying to do is bring blood pressure up, vasoconstrict. What's that also in this situation known as? Pressor. We're trying to bring up the blood pressure. And then an inotrope. What's an inotrope again? What does it increase?
The strength
Of
contraction.
the force of the contraction, right? So we're trying to get the blood pressure up and get the heart pumping. Makes sense why you would use this in advanced cardiac life support, right? Obviously, there are other uses for anaphylactic reactions, your EpiPens. So just knowing IM for your anaphylactic reactions, IV in a cardiac ACLS kind of situations. Here's another one, norepinephrine. Makes sense. These are the neurotransmitters, right? So there's issues with norepinephrine getting confused with other drugs. Often in the hospital, you'll see Levophed listed as an intentional way to prevent med errors. Like norepinephrine has been confused with phenylephrine, which is not cool because that's a nasal spray. It's not going to do a whole lot for advanced cardiac life support. So this one is non-selective again, but it does have an affinity more for the alpha than the beta, no beta 2 or beta 3. So it's a little bit selective. It's not totally non-selective. Again, the treatment is for hypotensive shock and cardiac arrest. Same idea to vasoconstrict, increase blood pressure. We want to decrease heart rate here in order to allow time for the heart to fill so that you can get a larger volume of blood when it does squeeze. And this is a continuous infusion. So these are, and then dopamine. Dopamine is a pretty potent drug. It acts on the dopaminergic receptors as well as alpha 1 and beta 1. So just these two. So you can see how it's going to vasoconstrict, and then it's going to open up the blood flow to the necessary, the most important organs like brain, heart, and kidneys, while the periphery is going to be vasoconstricted. This is one that has a lot of drugs in these categories have one action at a low dose and another action at a higher dose. And so just kind of paying attention to those, because I don't think they're going to give, I don't think they'll give you a low dose or a high dose on the exam. Just having knowledge, I think that this category of drugs can have different actions based on different doses. So if you end up being an ICU nurse, you'll be very familiar with what those doses should be, because you don't want to give something for the wrong reason. All right, so that's that one. So now the selective. So those were all non-selective. They kind of hit various receptors non-selectively. So if you pay attention to what receptors they hit, you know what they do. So this one is a selective phenylephrine, as we talked about. It's sometimes confused with norepinephrine. Phenylephrine is for your nasal congestion, not pseudoephedrine. Phenylephrine, this is the one that is in Sudafed over the counter, not behind the counter, right? Phenylephrine. So what we're doing is vasoconstricting the arteries in the nose so we can decrease congestion, right? We had mentioned this, oxymetolazone, which is Afrin, and these types of drugs can cause rebound congestion if you use them for a long period of time. Another one that gets used a lot is midodrine. And so this is used for symptomatic orthostatic hypotension. We want to constrict the blood vessels in our periphery and force all the blood to our core and our brain in order to keep our blood pressure up when we go from one position to another. There are lots of disease conditions that result in that. It could be Parkinson's may have it, all Parkinsonian syndromes can have it. People who are on a lot of blood pressure medicines may have orthostatic hypotension, but we probably wouldn't give them this. Anyway, so that's intentional constricting of our periphery. The guidelines that we need to make sure that we teach patients is don't give it within 4 hours of bedtime. Why wouldn't we give this drug based on its mechanism of action? What's the risk, or what are we concerned about?
Give insomnia?
Not insomnia. It has to do with blood pressure.
With their blood pressure.
Right. So when you're supine, this drug will increase your blood pressure too much and you can have a stroke. Like if you take it before bedtime and then you're laying down, the intention of it is when you're upright to push it into your periphery, push it into your central core. But when you're laying down, there's no resistance, right? You don't have gravity pulling your blood down. So now you're contracting and there's no resistance and you can really shoot your blood pressure high. So that's the teaching moment. Take it, it's better. And usually it's multiple times a day because it wears off, but we just don't give it in the late afternoon. All right, alpha-2. Now, clonidine comes up a lot because it has so many uses, right? Clonidine technically is an alpha-2 selective, and we use it for vasodilation and reduction of blood pressure, which is important in what? A hypertensive crisis. Somebody comes into the ER and they're super hypertensive, and in order to bring it down rapidly, clonidine is a great one. For alcohol withdrawal, oftentimes we'll get super high blood pressure, so clonidine is good for that. It's a multi-use drug. There's a little clip here about it, knowing the side effects of it, having to do with, it's not a discrete alpha-2. It doesn't only act on alpha-2, right? It's going to have a little bit of activity on some other receptors that are resulting in this dry mouth and the nausea and vomiting. And most likely it's having some beta-2 activity here where you have decreased GI motility. And so that can result in the nausea and vomiting and the constipation. It could also have some alpha-1, which is interesting. And that can cause, where's my, do I have a GI mucus secretion? Anyway, I don't see it on there. So knowing clonidine's an alpha-2 and what are we going to teach the patients to watch for, and just recognizing that a person, if you see clonidine, you can't assume what they're on it for. It could be for panic attacks. It could be, there's a lot of uses. So always say, what do you use this for? All right. These are all the adverse effects. A lot of them come from the vasoconstrictive properties of the alpha-1 because this one is like way stronger than alpha-2. Alpha-1 dominates in the alpha group. So we can get all sorts of problems if we have an issue with already with our blood flow to our heart. Right, nausea, vomiting. Yeah, and then the other teaching point is if you give a blood pressure lowering like clonidine, they may bottom out. You may get way more, and so that's the adverse effect you're watching for. In addition to dry mouth, nausea, constipation, vomiting, you will be monitoring blood pressure. It just may end up being 70/30 when they came in at 220/120. Some people just respond super fast. All right, so move on to beta-1. These are acting again. They're very, they are located mostly on the heart. And so this is butamine, right? And this is another sort of advanced cardiac life support type drug. Stimulates the beta-1 receptor, so it gives us all these things. It makes the heart faster, it makes the heart stronger, it increases or stimulates the electrical conduction of the heart to work properly. So it's good for people with heart failure, right? Because heart failure can be for a lot of reasons. Heart failure, by definition, is a structural change in the heart. And you don't notice it till you have symptoms of it. But you could have weakness in the muscle, you could have malfunction in the AV or the SA node. So yeah, people who come in acute heart failure who are knocking on death's doorstep may get this direct acting, but we don't have to worry about it. I'm not going to go too much direct acting, but the beta-1 selective. All right, beta-2, you knew already that if we're acting on bronchodilation, very common ones are both the short and long acting asthma and COPD drugs. So the short acting are more like albuterol, levoalbuterol, and then long acting are formoterol, salmeterol. This is a few. There's a zillion long acting. There's lots of money to be made off of it. So they work great. So these are considered, albuterol is a rescuer or a controller drug. Rescue, right? And formoterol and salmeterol then would be your controller. So you take your long-acting ones every day over 12 hours to keep your symptoms under control. Then you use your short-acting for flares of bad weather in the valley, upper respiratory infection, yada, yada, yada. But the more of this you add on to this, the more likely you are to have some side effects. And those side effects, I don't think they're listed on there. Most common ones can be like tachycardia. That's the most annoying one there is. Getting a little, yeah. Tachycardia is the one that people complain of the most, especially if they haven't used these drugs a lot. Just feel like their heart's pounding. Then the beta-3. So we did beta-1. Beta-1 drugs are mostly cardiac. Beta-2 drugs are mostly respiratory. Beta-3 is mostly bladder. Mirabegron has a new mechanism of action. We have some older drugs for bladder issues. This is a newer one, and because it's brand name, you have to fail all the old ones before you can use the new one. But it works on beta-3. We're basically trying to relax the muscles of the detrusor here in the wall so that it's not constricted. So it's relaxed so that you can get more volume in. It's a great drug, works great. We do have to watch for hypertension as the side effect. So I have to, when I prescribe this, I have to tell patients in the beginning, I need you to be checking your blood pressure because it does have that potential to raise, because it's not a discrete drug. It may have some of this, it may have a little of this. It's not just beta-3, unfortunately. All right, yeah, so this is beta receptors made easy. I think the betas are easier to remember than the alphas, you know, at least there's only 2 alphas. So really, if you learn alpha 1 and you know that alpha 2 kind of keeps it in check, really you only have to learn that. And then beta 1 is heart, beta 2 is lungs, beta 3 is bladder. And then dopamine is vasodilation to critical organ systems. Dopamine, yeah. So that's the best way I would suggest to learn them, is by kind of the category. First, learn what those categories do, plug the drugs in, learn what the side effects will be. So this is a mixed action, meaning they act. So there's 2 types of things. There's non-selective, which means that it can act on multiple receptors. And then there's another term called mixed action. So here's your spinal cord, and here's your preganglionic neuron coming, and you have neurotransmitter, and you have a thing here, a receptor, and then you have your target organ here and more neurotransmitters, and here's whatever the organ is. So a lot of times a lot of the adrenergic agonists act in this area. Some of them mixed, this is called mixed action. When it's acting both here for acetylcholine and here for either norepinephrine or epinephrine. So we're getting more bang for the buck. And there are mixed action drugs, ephedrine. We don't use that in clinical practice much, but it is a vasoconstrictor bronchodilator, interesting. The pseudoephedrine we've already talked about. It is a mixed adrenergic agonist, and we know what it does. We know what Sudafed does. Relaxes bronchial smooth muscles, and we use it mostly for relieving congestion in the nose. So we have phenylephrine and pseudoephedrine, both mostly used in the nose. These are our instructions. It keeps you awake at night. Take your last hours, a few hours before bed. So most of our overdose and toxicity comes from, most of it comes from the stimulation. These are agonists, so we're stimulating the activity of something. Luckily, most of these drugs are super short acting, and so they get out of the body system pretty quick. So if somebody overdoses, we provide supportive care for the symptoms until the drug works its way out of the system. If we have to, we might choose a rapid acting sympatholytic, meaning basically we're interfering with the sympathetic nervous system. We're breaking down the neurotransmitter. We're acting like an enzyme. But mostly symptomatic support until the drug gets out of our system. That's kind of important to know. I think it shows up somewhere on an exam or a quiz, or I remember this one. Lots of interactions. So obviously, if you're taking an agonist that stimulates this, you don't want to take an antagonist, right? You're just canceling each other out, and now you're taking 2 drugs for no reason. You're not going to get the benefit of either, and you may just get the side effects. And then just sort of knowing that MAOIs have an interaction, antihistamines, thyroid drugs, there's so many. So anytime your pharmacist generally will do a drug interaction in the hospital just to make sure everything's copacetic. But the main thing is don't take an antagonist when you're taking an agonist. Here's a question. All right. So dobutamine, where did dobutamine come in? Okay, was it selective or non-selective? It was non-selective. Do we need to go back? I can go back if you need to find it. Should be taking notes here. It's going to show up. They love an ACLS drug.
Oh, beta 1 is hard.
So patient on a dopamine drip starts to complain that he feels a tightness in his chest that he's not felt before. What will the nurse do first? Check the infusion site for extravasation, increase the infusion rate so we can address chest pain, check the patient's vital signs, order an EKG. What do you think? Vitals, right? This is one of those trick nursing questions where really we want to assess before you do anything else, right? So always we do that. We don't monkey around with the dopamine rate. Extravasation of an IV is not usually going to cause chest pain, and obviously we might get an EKG, but that's not our decision.
Can you tell us what's happening actually? What is it? Is it too much?
Yeah,
The action of the.
yeah,
medicine?
he's got too much, right? He
Okay.
has too much activity. The patient is brought to the emergency department while having an asthma attack. All right, asthma, right? We're already thinking which adrenergic receptor? Beta 2, right? So that's how you start reading these questions. Patient's given a nebulizer treatment with albuterol. Okay, that's a short-acting beta 2 agonist. What's the nurse's immediate assessment priority? When was his last meal? Monitor his oxygen, monitor the temperature, provide education on asthma management. So we're trying to follow the nursing process where we assess the outcome. We might do this later on, but I don't think when they're in an asthma attack, we need to start giving them asthma education. Why are you having an asthma attack, right? So we're giving this fast-acting drug. We want to monitor for the response. That's all in that assess, diagnose, which is not diagnose, which is not nursing. Human needs statement. Assess human need, plan, implement, evaluate. So this is the evaluation, right? And then we phrase a question asking you what phase of checking the oxygen, of what phase of the nursing process is it when the nurse checks his oxygen? Assessment? The evaluation, because you're evaluating your intervention,
Yeah.
which was
Well,
the
then would it say
alcohol.
monitor or checking the patient's oxygen after administering or while administering? Because of checking oxygen, that's part of our science, assessing the patient, because you would check it before and then you would.
It's considered, well, it's considered the evaluation of the intervention. It is. Go figure. All right, everybody knows our adrenergic agonists now, right? Didn't cover a whole lot of drugs, just a few, some of the basics and what you need to know, which is helpful, I think, not to laden you down with too many. Oh, that's not what I want. I want modules. Go back here. And then come down here and we'll look at this. All right, so now we look at the opposite, which really is very logical. If we look at blockers, you automatically, if you know this, you just say, oh, we're doing the opposite of it. It's not super complicated. We're just doing the opposite.
Would you say that the blockers are more used than the?
And more on a day-to-day basis. I mean, this is every day. This is more like advanced cardiac life support. This is day-to-day. This gets used some. Slideshow from current slide. All right, so we're looking at the blockers now. Pretty easy. So it binds to the same receptors, but it is somehow is interfering with the effect of whatever the stimulation is. These are the terminology, so adrenergic antagonists or sympatholytic. And we saw sympatholytic as an antidote for an overdose of adrenergic agonists, right? That's where the terminology comes in. Just knowing these are the opposite of this. So again, review, this is the sympathetic nervous system, right? This is another big picture of everything that happens. And so you've got, this is in the slides that you'll have, it's not in your book in such a nice way. I like this better. And the handout here that's on the table, if anybody wanted one to fill out, there is the sympathetic division, and the other one is parasympathetic, which we'll try and get to. Maybe see if anybody else wants one. Anybody want a sympathetic, parasympathetic worksheet? No, because you know it. All right. So let's see if I can make this say anything. What are the effects? So weird. Oh, maybe it's like this. No, I don't know why. Screw that. All right. I made you a quiz with wrong answers. I can't get my videos to work.
It's the weekend.
No, I have no excuse. None
It's not enough
whatsoever.
caffeine.
It's all Destin's fault because I'm cutting down on the caffeine.
Toward this. It's gonna turn purple.
He's a good influence on me. All right, alpha blockers. So they try and block the effects of norepinephrine from constricting. We can think about it either as inhibiting vasoconstriction or just think about it as vasodilation, right? It's one is technically correct and the other is just easier to remember. And so we use it in hypertension because it can cause both arterial and venous dilation. It's not a first-line hypertensive drug. It's like a third or fourth line antihypertensive drug. It does reduce peripheral vascular resistance. So just like with orthostatic hypotension, we were trying to squeeze all of our periphery. In this one, we are trying to open it. And so you could see that might be used in somebody who has peripheral vascular disease. They have a lot of occlusion down there from years of smoking and eating bacon. Don't eat bacon while you smoke. Anyway, so we would want to peripherally vasodilate. There are great drugs that work that way. So typically what we're using alpha blockers for is for men who have an enlarged prostate. So here's your bladder, right? Here's a happy bladder and your urethra and your prostate, and there's a good flow. But the one organ of the man's body that keeps growing throughout its life is the prostate. And so it keeps growing and this urethra gets narrower and narrower. And it's harder and harder to empty the bladder. And so what we can do is kind of shrink this up so that it's easier to get urine out. So we use an alpha blocker. These are the side effects when we use an alpha-1 blocker. And this is a general statement about all drugs that can hit blood pressure, is there's a first dose effect. Okay, what's first dose effect, Nassaran? You know this one. When you take the first dose of a drug, what? When you take the first dose of a drug that's going to vasodilate, what are we at risk for? Vasodilating. Yeah, decreased blood pressure. We're at risk of hypotension with that first dose. So alpha blockers that are used to open the prostate, well, we have to educate them. It doesn't make any sense to them. Why are you telling me to, watch my blood pressure and stand up slowly? And this is the reason, because of this phenomenon of the first dose effect. It's going to vasodilate everywhere. And then we end up with this postural hypotension, right? You're hypotensive because everything is vasodilated. When your blood pressure drops, you get tachycardia. That's your heart's compensation for a low blood pressure, is that they speed it up in order to get more oxygen around. Headache, remember we said that vasodilation is the thinking that that's the reason we get headaches. So headache, nasal congestion, right? Because we may have used an adrenergic agonist to relieve congestion. So if we block it, we're going to get nasal congestion. All right. So, you've already going to know the answer. When administering an alpha blocker for the first time, it's most important for the nurse to assess the patient for the development of what adverse effect. Yeah, we already gave you the answer, hypotension. First dose phenomenon is a severe and sudden drop in the blood pressure after administration of the first dose of an alpha adrenergic blocker. And it's pretty remarkable, and I have seen it before, where little old men just stand up and pass out. You know, that's when they break their hip and all that stuff. So you just have to teach them about it and the precautions that we teach people who may experience orthostatic hypotension.
Don't they say that usually like the first time you take it like around bedtime so that.
I mean, that's oftentimes the thinking on blood pressure meds, but if this is a medicine that is allowing your urine to flow more freely, you probably don't want that to happen at bedtime. Right?
Let's just look at it.
Yeah, so I mean, this is like real life dealing with patients type thing. Yes, that is the general philosophy that, you know, drugs that drop blood pressure, we say take at night. I always say, well, then they're just gonna pass out in the night when the light's off, but that's the thinking. Just think of the whole patient picture.
This says it wears off after a while. But taking the
Yeah.
medication really-
Generally speaking, on alpha adrenergic antagonists, that phenomenon, as they get used to it, that phenomenon wears off. So these are some common ones. So tamsulosin, terazosin, doxazosin, prazosin, alfuzosin, what do they have in common? Hey! Or osin, it could be a zosin or a sosin, a luosin. Osin, there you go. So these are the most common ones on the market. Every little old man over the age of 65 is taking one of these. They say I'm taking it for urination. Well, technically they're taking it for their prostate, but whatever. These are, what are they? Oh, acronyms, if you're into acronyms. I'm not much of an acronym person, but this is saying, here's an acronym of what we give it for. Here's an acronym of what you look for. If you happen to learn better that way, go for it. So tamsulosin is probably the oldest and most common on the market of an alpha blocker for BPH. And you will see women on it. And you'll be like, well, okay, so is this a trans person, or why is this female on it? And it's for kidney stones or urinary retention, because we are sort of vasodilating that area. So you will occasionally see people on what we consider to be a man's drug. It's not an antihypertensive drug, however. This is the one in this class that we don't use for hypertension. Doesn't have that much effect on blood pressure, which is why it's first line, because we're less likely to have persistent symptoms of low blood pressure. So knowing that tamsulosin is the exception to the osin rule. And then there's lots of, potential adverse effects that we talked about, but yeah, osin is the key with it. So that's our alpha blockers. Beta blockers. I'm sure by now you've heard the term beta blockers, right? Oh, he's on a beta blocker. We're going to give him a beta blocker, an ACE inhibitor, or an ARB. Beta blocker. Well, they're talking about this beta, right? Beta 1 receptors. So we're using this for cardiac conditions, for whatever. There's a myriad of reasons why we use them. So we have selective beta blockers that only act on beta 1, which are the preference. We call them cardioselective because where does beta 1 act? On the heart. And then there's non-selective, which are the older school. And there's a little more like precaution with them because we don't really want to have necessarily this activity as well. If somebody has COPD, we don't want to block bronchodilation, right? So there are some limitations with the non-selective ones, but we love the selective ones. So these are the actions of what happens when we block beta receptors. Okay, now instead of stimulating the electrical charge through the heart, we're slowing the conduction. And when we slow the conduction, we have more time where the ventricles are relaxed, more time for filling, and then we dilate arteries that are receiving that blood, so there's less resistance. The blood can flow easier, less work on the heart. So if you already had a heart attack, you want to make sure you have less work on the heart. That wall may not function properly, so you want to allow time for that to fill and then give the least amount of resistance as it goes out. Makes sense. So we do use some of them for other reasons, like migraine headache because of the it's from this lipophilicity, and some topical use in glaucoma, but mostly these are the things we're using it for angina or angina, however you like to say it. I always say I don't like to say angina because people think I'm saying vagina. I say angina because nothing sounds like angina. So what is angina?
Chest pain.
Chest pain from lack of what?
Oxygen.
Lack of oxygen, right? So decreased blood flow, lack of oxygen. So we take it because we're decreasing the work of the heart, right? If we're doing this, we said he had a heart attack and we're decreasing the work, how hard that heart has to work. That's what's important. If the heart doesn't have to work as hard, it doesn't need as much oxygen for its function. I mean, the heart's probably the most important muscle you've got in your body. So reducing the demand for it while still having sufficient forward flow is pretty important. It is considered cardioprotective, and it's because it plays around with these neurotransmitters and inhibits them, because these circulating catecholamines have other effects within the system, let's just say, and on the heart, yeah, specifically. It's kind of a long chemical thing, but just know that we consider it cardioprotective, so we use it in all patients who've had an MI. They're going to get a beta blocker, standard of care beta blocker after an MI. There are other uses like rhythm issues. We use it as an antihypertensive, usually if they have another reason. I wouldn't go to a beta blocker first because people don't feel great on beta blockers often. And there are other drugs that have less issues. So we use it in heart failure. People who've had an MI end up eventually with heart failure. Well, if you've had an MI, you automatically have heart failure because heart failure is structural damage. But those are the general uses we use it for. So beta 1, the cardioselective, right over here, all of the things that we've talked about before. Decrease heart rate, slow the conduction, allow the ventricles to fill. Super straightforward. These are the cardioselective beta blockers, and I've kind of listed atenolol and metoprolol are the most common I've seen out there. Nebivolol and esmolol are less common, but they're still out there. And so you may see these on the market, metoprolol, low pressure, toprol XL. It's really important to pay attention on metoprolol because often metoprolol is written metoprolol, but there are two formulations. There's a short acting and a long acting. And short acting is given twice a day and long acting is given once a day. So you need to pay attention whether it's metoprolol tartrate, which is short acting, or metoprolol succinate, which is long acting, because you don't want to give a long acting twice a day. You'll give him a big beta blockade, and it may slow the heart so much it goes into an abnormal rhythm. So yeah, paying attention to those.
I'm sorry, so the titrate is the one that takes twice?
Titrate is, metoprolol titrate is the short acting.
And
And metoprolol succinate is long acting. Yeah. So let's see, atenolol. Beta blocker, we said it's used standard of care beta blocker after a heart attack. And it's used to prevent one because we're dealing with this cascade of catecholamines after a heart attack. We use it for hypertension, chest pain, same thing. We also use it if somebody's having a thyroid storm because they are hyperthyroid for whatever reason that causes blood pressure to go up, pulse to go up. The thyroid is sort of like the engine of our body, and it tells us how fast everything should run in general. So if you're in a thyroid storm where everything is just on high speed, you're in like 8th gear revving, then we will use this to slow it down while we treat the underlying condition. And of course, atenolol is just your everyday over-the-counter drug. Metoprolol is the most common one. It's given oral and injectable, so meaning IV. We talked about this, succinate and tartrate. Just being aware so we don't bolus somebody with the wrong thing and stop their heart, because then we'd be in trouble. So beta blockers, if we give them with drugs that have other beta blockade activity, obviously you're going to get synergistic effect, more than 1 + 1. And of course, we don't want to give it with something that is an agonist. Sometimes you have to. Sometimes you have to give somebody a bronchodilator at the same time as they're taking a beta blocker because they have asthma and heart disease, right? It's just the way life really is. One of the things they like to talk about and test you on is that because it's a beta blocker, people with diabetes may not recognize they're hypoglycemic. And so what would the symptoms be there? Besides, I mean, I guess it's on there. What symptoms are they masking? Because when you're hypoglycemic, you can be tachycardic. And if you have a beta blocker slowing your heart rate, you may not recognize that you're hypoglycemic. So it's one of the things you teach patients about when they're started on a beta blocker. Teaching, remember, is the focus of all this. It's not just the knowledge, it's the application of the knowledge. We teach patients who are diabetics, you know, when you start this drug, you need to watch for your blood sugars. You may not feel that you're going low, but this drug may, I would say, cause you to go low, even though it's not a cause. It's just easier to understand. All right, non-selective. So now we're hitting both of these. Probably not for very much. So non-selectives act more on beta 2 than beta 1. And we get bronchoconstriction, shortness of breath when that is overly activated. So let's see if we can see a drug. All right, carvedilol, super common now. Studies are showing this is a super effective drug, but it's non-selective. So there is a precaution with the drug that if somebody has started on a non-selective beta blocker and they have an underlying respiratory condition, generally we're like supposed to be wary of giving them non-selective. And so we still teach that and study that if you have COPD, advanced lung disease, or severe poorly controlled asthma, we want to avoid a non-selective beta blocker because of this, make their lung disease worse. In reality, it's not so true, but whatever. So recognizing these names, what do you see on the end of them? This one and the other ones. Olol, right? So if you see Olol, you automatically know it's a beta blocker. Just like if you see Osin or Zosyn, you know it's an alpha-1 blocker, right? That's a nice way to remember these things as a class. So we talk about propranolol as the prototypical. Remember, prototypical shows up. Always know any drug that says prototypical has so many uses, so many. Not just cardiac, but it's used like to prevent headaches, for essential tremors, for public speaking anxiety, for panic disorder, for the list goes on and on. There's so many uses where we want to interfere with the catecholamine flow. So it's a great drug, but you have to take it multiple times a day if you don't like it that much. And then the other one that's super common, as I mentioned, is carvedilol. It acts on alpha-1 and acts on beta. And so it has a lot of non-selective activity over here. We do know that it slows the progression of heart failure because heart failure is a chronic progressive condition. It's a terminal condition. There's no cure. It never gets better. It only gets worse. And we use it in this category. And so this is the inpatient one that, well, you'll first start it inpatient. I don't know if I've ever seen it outpatient, although I think it's possible. It's for people who have rhythm issues, so it's not necessarily the rate. You're not having a crazy rate, but people who have like ventricular rhythm issues, and the ventricular ones that are the ones that are more deadly. And so this would be prescribed by a cardiac specialist. But knowing that it's a non-selective beta blocker and Sodawall as an example in an inpatient setting is a good thing to know. All right, what are all the adverse effects? We talked about you don't recognize hypoglycemia. So we're supposed to use it in caution with patients with diabetes. Here's another acronym if you're interested in that. The bald fish. Bald. I didn't make it up. Somebody else did. The bald fish. In disturbance in glucose metabolism. Yeah, that's kind of saying the same thing over here. So it'll be on the PowerPoint when I post it if you want to do it that way. So here's our memory trick for beta blockers. Ending in OLOL. If they start with A through N on the generic name, it's a beta 1 cardioselective. A through N. If it's O through Z, it's non-selective, with the exception. There's one exception. This one would be selective. But in general, A through N is selective, O through Z is non-selective. Yeah, makes it easy. Just learn Sodawall that it's the little bastard outlier. And this is when we don't use it. That goes without saying. We need to make sure that we've taken care of the status of heart failure before we start blocking things. Obviously, if someone has different degrees of heart block, be careful. If they're already bradycardic, we have to be super careful. Care with pregnancy. We talked about why lung disease. And then Raynaud's disease is a disease of peripheral vascular vasoconstriction. So we don't want to use a constrictor in something that's constricted. All right, so how do we manage overdose? So we're treating the symptoms. What are the symptoms the patient has? Are they super bradycardic? Okay, then we're going to give something that's going to stimulate the heart rate. We give typically atropine. If they're super hypotensive, we're going to go back and give oppressive. And then if there's lots of toxicities, we use hemodialysis. So there's not one like, oh, we give naloxone, you know, if that's the answer to it all. We treat and try and reverse the symptoms that they're having of the overdose of whatever they were on. All right. You can take a break if you need it. We'll come back and see if we can figure this out. Dance, jump around.
What are the lollipops?
No.
No?
I taught at the U in the DNP program.
What are the lollipops they institutions?
Like fentanyl lollipop?
No lollipops.
Oh my gosh, I'm learning so much. I'm having so much fun because it's like
stuff starts to make sense.
I know, there's just like such a new world, even though everything's like really.
Yeah,
But because we were at the VA yesterday and they took them out to Olive Garden and somebody just flipped and started like calling people names and get really agitated. So we just gave him a lollipop.
But like.
Oh, I wonder if it was just a lollipop.
A lollipop, so
So-
yeah, that's just.
My husband was up at the U in the ICU for a while, and he would get really like, I was anxious, and they gave him a lollipop. The nurse said it's fine. I'm like,
That would be sort of an off-label use.
well, he.
No, but I mean for this older adult.
Oh, right.
He is an
She
OB.
said lollipop, and I'm like, that sounds familiar.
Because I'm trying to think, like, other than just like Tootsie Pop.
I mean, maybe, I know like when I took my son's soccer games and I'm screaming too much, they give me a real lollipop.
Yeah.
Want me to sit down.
So they just, that's what I thought that the sugar would just kind of.
And maybe it's just something else to distract. A lot of times it's just distraction. I would be hesitant to give a drug like fentanyl to an old person.
Yeah.
Yeah.
My husband's
Oh,
like,
my
can I have more of those?
death.
Give me more of those. The nurse is like, I can't give you more.
Yeah.
It's like, can I take some of those home?
And that's the purpose of having this class when you're having clinicals is to put the meds together with the conditions, with the patient, and really pay attention. I know that it's annoying to look up meds or review what meds are being given, but it helps. It helps stick in your head when you see them in practice.
Trying and like, I think we were talking, I just wish we had more time to just, go in.
Absorb.
But it is what it is.
Yeah. More time to absorb and digest.
So we were talking about, was it Flomax?
Yeah,
We had
Flomax.
2 patients with Flomax.
I totally thought it was for asthma. Is there something that sounds like
No,
that?
there's Flonase, which is nasal spray.
What is the tube called that you use? for-
There's fluticasone, which
Hmm.
is an inhaler or can be.
And they both had the benign.
Yeah, it's just inevitable.
And that's really only in men?
Yeah.
We have prostate. Do we have prostate? No.
I mean, maybe you do. I can't.
I don't think so.
Maybe I do. Maybe. I don't know.
Maybe.
Okay,
Maybe you have like Turner syndrome, that XY, if you actually do have a prostate. Just thinking.
We had this patient that had lost both of his legs. And in order to straight fix him, we had to like turn him on his side, with his leg, angling just right, because his prostate was.
It's awful when it gets that big.
And it was like, he's like, oh, let me move this way, or let me, and it's so, such a struggle.
So usually they get put on an alpha blocker and then another class of drugs, shows up as finasteride. Works in a different mechanism, but the idea is the same to open that up. But even with that, and we sometimes do double dose of Flomax. Even with that, you just can't stop the growth. And some people just grow. Or they may have an early cancer, but they're not gonna die from it. We're not gonna do anything about it. The surgery is worse than that. Yeah, the surgery and the consequences of surgery are usually worse than just having issues with flow.
I'm sure this is a really stupid question, but why do they need a prostate?
I'll let you Google it. 'Cause, yeah, what does prostate do?
It makes semen, right? Where it's like some of those,
Oh,
like
the
the
lower
lower
vent.
posted and then you have like any recordings of the classes on
Oh.
YouTube or anything like that.
Huh.
It makes all that.
No, because I had to point out about this.
Oh.
Say nicotine.
I've been heard of it, maybe.
Nicotine receptor.
Um,
I was thinking about that the other day.
I would only, I remember supporting. I would not be that.
What in social media? What increase people's anger at me?
Social media, what?
I was wondering if she like posted some for recordings of the classes on YouTube.
There's enough out there.
Okay, I'll try.
There's enough out there.
Honestly, don't know. I have tried though.
I think if you watch enough of them in a row, then it all, even if they're not perfect, you get the gist of it. You get the main highlights, because if this is repeated in this one and this one and this one, then that's the basic of it.
Okay.
Not that you have hours and hours to do that.
Oh, I like those recordings because every Sunday I have to drive to the work, so it's like 5 hours in the car. So I like to use those 5 hours.
Yeah, there you go. I'm sure there's lots of things you can podcast and just listen to. I'm sure. All right, so let's see, we've got so much. 10, 20, and then Monday. Let's talk about, because we have to, maybe we might need to skip this because we need to finish this, and then I'm standing over here because this is where I draw the parasympathetic nervous system. Makes it easier. So then when I say, remember when we were talking about the sympathetic, and then I say, remember when we were talking about parasympathetic? So on Monday, we will finish up everything that's missing from today, because there's no way we can get through 2.5 more chapters. But do you want to do some sort of review of something?
Yeah. Let's do the review.
Okay. You want me just to be boring and like, I mean, how do you want to do it? Whatever makes it, how do you learn best? I mean, I can make, the question and answer slides. I can, we can just sit here and I can say, what questions do you have? We can
Battle to the death.
battle to the death.
So the Jeopardy was really helpful.
Yeah.
That was
There's only a certain amount of questions on that. That's pretty limited by like 6 by 5 is 30 questions or something, 6 by 6 is 36, where I had 125 on the last one. So I had a lot of variety of things to reinforce the key topics. Maybe I think we'll do that. Just
And we could also just do, I found it helpful, even with like bingo, when you were listing off the questions, and then we're all just trying to come up with the answer first.
okay. Well, I want to make everything as meaningful as possible because I know it's a lot and your head is like, like a cartoon where the stars are all just swirling around. And you can get it. You can get it. I promise to all that is holy on this earth, that if you just learn that, the rest is easy.
And if you just learn what drugs are in which.
Yeah. If you just learn your receptors, then you say, oh, my OSIMs are all alpha adrenergic agonists, okay, or antagonists, sorry. And so I know that I'm doing the opposite of something over here on the alpha drugs. We're good at this. All right, we got too much. We can't do a group thing. The nurse knows that the adverse effects of a non-selective beta blocker are likely to be the most immediately life-threatening in which patient?
Is it B? Is it B?
Yeah. So look at the reasons why the other ones were not right. Okay, it can mask signs and symptoms of hypoglycemia, but that is not going to be as demanding as somebody who may bronchoconstrict, and it's just a matter of prioritization. Yeah, hypertension, you're just looking at that going, wait. So these are all the things. People often run out of their drugs. I don't know how many people forget to, okay, so they forget to reorder the refill, or there's an issue with their insurance, or the prescriber says you have to come to the office before I'm going to write a new prescription. And it can be a big deal if you stop taking a drug that's controlling your blood pressure. If you stop taking a beta blocker, you may end up with rebound hypertension and rebound tachycardia and be super sick and end up in an ER simply because of this rebound or rebound angina. You were having decreased workload on the heart, so everything was flowing well. You had adequate blood supply that your drug stopped, and now your heart is ischemic again, working hard. That's a recipe for a heart attack. So these other side effects are that oftentimes people don't feel well. They don't feel like they can do as much as they used to, and this may or may not go away. I don't like to emphasize it because lots of people need to be on beta blocker drugs, but it is unfortunately people who are in their 50s and have a heart attack are going to be on a beta blocker, and they may have been someone who is physically active and they just can't do what they used to do anymore. And it's like, well, maybe you can get off of it in a while, because beta blocker may not be for life in a young population, but that's the unfortunate one. And then this one is sort of just a generalized statement, because like beta blockers are used in heart failure. So this is really just saying, okay, if this patient has heart failure, then what are the symptoms of what we should be teaching them to monitor? And lots of times that gets forgotten. So we tell them, how do you tell them to check their weight? What's the teaching on that?
Same time every day.
Same time every day. Yeah.
Like food retention.
Yeah, so just same time every day, whatever time that is. I don't care what time it is. You can do it at bedtime if you want, but do it at bedtime every day. I'm not, lots of people say, just do it in the morning when you wake up. But some people just don't want to. So do it when you do whatever, but do it at the same time. And then knowing the parameters of sort of, if we get to, lots of times they'll skip over this one. They'll be like, oh, you know, I didn't have a bowel movement, so all right, it'll be better tomorrow. But if they get to a week and they're up 5 pounds, then somebody needs to know, because that's a whole lot of bowel movement trapped in there. And all of these other symptoms of poor heart function, so building up of fluid, pulmonary congestion. So that's all of that. All right, we did that one. Woo woo, that's what you need to know in general on the sympathetic nervous system. Everybody got it? It's memorized? Excellent. 100% for all of you. Yeah. You can do it.
Turn off the speaker. The buzz is over here. The buzz is buzzing. Yeah.
Oh, there we go.
Let me turn that down. Sorry. You have to remember. So adrenergic blockers. Okay, cholinergics. Woo, I love cholinergics. Just love drugs in general. Let's get this guy down. So this is, because I know you've all read and done your exercises, you'll know that we're talking about parasympathetic nervous system now. Right? Which is the balance to the sympathetic. Come on, show me my thing. Done. All right, so this is all terminology, right? We said by definition, it's the balance to the sympathetic. So then they also have, you'll see all of these other terminology show up talking about drugs that act on the parasympathetic nervous system. They are cholinergic drugs or parasympathomimetic, just like these are adrenergic drugs or sympathomimetic, right? Same thing. The neurotransmitter is acetylcholine, so they're cholinergic, and it's the parasympathetic nervous system, so it's parasympatho, mimicking the parasympathetic nervous system. So this is sort of the overview of our wonderful parasympathetic nervous system. We're back. So in the sympathetic nervous system, most of our nerves came from the spinal cord. In the parasympathetic, they're really coming more from the basal ganglia, and they have the same thing. They have, this neuron, and then a synapse, and then where it's going to act. And this is acetylcholine here, just like it was in the sympathetic nervous system. Look, this is supposed to be a gap, right? We need our neurotransmitter. And it's acetylcholine here. What was it in the sympathetic nervous system over here at the target organ?
Adrenaline.
Epi, norepi, right? Those are the neurotransmitters. Epi and norepi. Except for a little bit of acetylcholine, because here's the spinal cord. Yep, here's our acetylcholine is here. And
Go to our effector organ. And these ones, epi and norepi, are here. So a difference in neurotransmitters, acetylcholine. And that's why they're called cholinergic. You can figure out the reasons why the terminology happens. It helps you not get overwhelmed when they switch from one terminology to another terminology. So the way I was telling some people to remember, this is adrenergic because the sympathetic nervous system, remember, it acted also on the adrenal gland. Adrenergic. Get it? That's how you remember sympathetic. Cholinergic, if you remember, the only neurotransmitter is acetylcholine. Makes sense. See what's next. And I love this video too. I'm not going to go over it, but this just makes so much more sense. Who's it by? Follow the link. It'll go there. Yeah, the link should be active. Let's see what's here. Yeah, I think we need to start at the beginning. Let's see. I can make this go. Enable editing. This. Huh? See if we can see what the heck's going on. Probably hit too many buttons and it's in a panic. That's a very small thing, huh?
The parasympathetic nervous system is a subdivision of the autonomic nervous system, which is a subdivision of the peripheral nervous system that controls automatic processes in the body, like digestion, heart rate, and respiration. The parasympathetic nervous system is typically associated with energy conservation and processes like digestion and elimination of waste products from the body. Because of these functions, the parasympathetic nervous system is sometimes referred to as the rest and digest system, although this term is an oversimplification that does not accurately describe the full range of activities of the parasympathetic nervous system. The nerves that make up the parasympathetic nervous system originate in the brainstem and the sacral spinal cord. Like most other neurons of the autonomic nervous system, they do not travel directly from the brainstem or spinal cord to their targets, but instead extend first to clusters of neurons known as ganglia. The parasympathetic ganglia are typically found near or in the wall of the organs they supply. The neurons that travel from the brainstem and spinal cord to the parasympathetic ganglia are called preganglionic neurons, and they synapse with neurons in the ganglia called postganglionic neurons, which then extend to the targets of the parasympathetic nervous system. The preganglionic and postganglionic neurons of the parasympathetic nervous system primarily release the neurotransmitter acetylcholine. The preganglionic neurons that originate in the brainstem arise from the cranial nerve nuclei for the oculomotor, facial, glossopharyngeal, and vagus
There's
nerves.
a little extra detail.
These preganglionic neurons travel with the cranial nerves to provide parasympathetic innervation to the head and neck, but the fibers that travel with the vagus nerve also supply the internal organs of the thorax and abdomen. The preganglionic neurons that originate in the sacral spinal cord come together to form the pelvic nerves, which supply the organs of the pelvis.
That was a lot of stuff that, yeah, that's just the, well, don't play again. Just be nice. Sorry. Let's see if we can. I push the button too many times and then I wait. All right. So that's the physiology of what's happening. So there are places where we can have activity. We can act here on neurotransmission and either increase it or we can block it. Or we could act here and increase it and block it. And these are direct and these are indirect. And that's just a technicality. But the reason that we talk about indirect is because what we're doing is interfering with the enzyme. Remember we said the enzyme is going to break down the neurotransmitter? So in this one, indirect, we're interfering with the enzyme that breaks it down so that the drug stays in the system longer. And we have more acetylcholine. These are the two mechanisms of action. Basically, it either binds here, the receptors, or we're interfering with the breakdown and recycling. All right. So the indirecting, there are reversible and irreversible. That's nice to know. And it is because some of the drugs are reversible, and as it works its way out of the system, the effects wear off. Some of them are irreversible. They stay in the system for a long time, and you have to make brand new enzyme. Your body has to create it. All right, so what do they do? So the basic function of the peripheral nervous system is what? I mean, in general, what it does is inhibit the sympathetic nervous system. That's the general activity, because we're inhibiting this. So if we take an agonist that increases the inhibition, like a double negative, right? If we take something that makes the peripheral nervous system go, then we inhibit the normal activity of the sympathetic nervous system. That's why I say, if you know these, then you automatically know this, because this is just inhibiting it. All right, so here we go. Heart. We've got decreased heart rate, decreased blood pressure, vasodilation. Those appear to be opposite of alpha drugs, right? So by inhibiting that activity, this is what we get. It's almost like an antagonist, like an adrenergic antagonist, almost like that, but it's a whole different system. And that's because our body has multiple checks and balances. We don't want to, if one thing goes out, the whole thing goes to hell in a handbasket. And then we get bronchoconstriction. Right? Which, if you took an antagonist, would be what happened over here. All right, here we go. We increase intestinal activity. So who wouldn't want to take a drug that was a cholinergic agonist if the drug causes increased intestinal mobility? No, people who have a bowel disorder that causes like irritable bowel syndrome with diarrhea, or a malabsorption syndrome, or they've had part of their ileum taken out, and so now they're have a huge output. So you wouldn't want to take a drug, right? So that's automatically, you could think, okay, well, that's going to be a contraindication. When we learn what drug it is, these are the groups that we're going to want to avoid. We don't want to give this drug necessarily to a person with COPD, right? We may not want to give it to somebody who has terrible orthostatic hypotension, right? It kind of makes sense. So we get increased urination. That could be good or that could be bad. And reduce intraocular pressure. That's one, because you could see what disease would we use that for, right? Glaucoma, straightforward. As if intraocular pressure. So just by looking at what it does, you can see the uses. Well, okay, if somebody's maybe hypertensive and maybe, they need add-on drugs, maybe we need to use it. Another one here is increased salivation. And sometimes that's desired. Somebody who has Sjogren's syndrome,
Sjogre, something N like that. That's a way to go. Sjogren's syndrome, they typically have like a super dry mouth, like their mouth, their tongue will crack. So if we want to increase salivation, that's great. We have a whole category of drugs that can increase salivation. All right. The direct acting. So most of the uses of direct acting are topical because we don't want all of the effects systemically. We don't want all of this throughout the whole body. So we just use them mostly topically for like reducing intraocular pressure. And this is the example of the drug that gets used, pilocarpine. So that way we can avoid bronchoconstriction and increase urination and all of that. Just keep it local. There are some oral ones. I just mentioned it because I saw it come up on Hesse one time. I don't know if it will be this time, but I saw this drug. And so this one is used to relax the bladder sphincter so we can so that we can increase urination, right? So people who had surgery oftentimes have atony of the bladder. What's atony? Yeah, it's just been no tone. A means without, tony is the muscle tone. So their bladder is not constricting, right? You've got people, you're waiting, they've got a catheter in, you're waiting to see if they can void on their own. And so we can give them something that may help with that. If they're postpartum, if they have a spinal cord injury and have a neurogenic bladder or a spinal cord affecting disease, that may help. And then, so that's the oral one. The IV one is succinylcholine, and that does show up for you needing to know. So this is an IV drug. It is an ultra short acting drug, in and out, skeletal muscle relaxant. It's used as an adjunct to the NMBDs in general anesthesia. So that's where we saw it before when we were talking about anesthetics. We saw succinylcholine. We didn't talk about it a whole bunch, but we talked about it a little. This is where you see it used and what sort of category it is. It is a cholinergic agonist. Sorry, acetylcholine, yeah. Cholinergic, that's the terminology. And right, so these are it can be super fatal. That's why it's done in an inpatient setting because of some of the more severe side effects. So we talked about these muscle fasciculations before, where there's like muscle twitching and firing to the point that there can be muscle damage. Muscle damage releases potassium. If you release a bunch of potassium, you can become hyperkalemic, which can cause a cardiac arrhythmia, which can cause death. And there is no antidote.
But I thought that dantrolene was used.
This is there. This is used as an adjunct to neuromuscular. As a neuromuscular blocker as adjunct to general anesthesia. It's used as this, but this is actually a cholinergic medication. Let's see what else we got. Indirect acting. So more of the drugs are indirect acting. And so we're acting to increase acetylcholine. Here's our synaptic cleft. Let's say we've got this one. There's our neurotransmitter, and this is the vesicle that binds to the wall. And then here's the synaptic cleft, and wherever it's going is over here. And so what we're trying to do is once this is fired, this ruptures, right, and it's released into the cleft, and it gets taken up here, and then it's either broken down and recycled. Well, if we can keep it here longer, maybe these receptors aren't functioning well. Maybe we've had some destruction to them, or maybe, yeah. So if we can keep this neurotransmitter in here longer, we get more activity. Well, the way to keep it, so that's our skull and crossbones. That's my skull, because I can't draw a skull. Skull and crossbones, this is the enzyme.
which is colon ester, ACE, right? ACE is always an enzyme. So this is coming along and it wants to break it down. So we have our ingredients to make new one and recycle it back. Well, if we can interfere with this, right? Now the neurotransmitter is hanging out there, has a long time to have its effect. So these indirect acting drugs act this way. Awesome mechanism of action. I don't know how they thought of it. So one of the key drugs that we learn about is for myasthenia gravis. You ever known anyone who had myasthenia gravis or know what it is?
I've seen pictures.
Yeah. So from a pathophysiology standpoint, okay, so here's our nerve cell, here's the synaptic cleft, here's our effector organ, right? And we should be getting a lot of neurotransmitter in here. These are going to be all of the receptor sites. Well, in someone who has myasthenia gravis, they've had damage to a lot of their receptor sites of muscle cells. So you have loss of muscle function. It's kind of sad. It is an autoimmune disease. So if we can keep that neurotransmitter in here for longer, we're not asking this neuron to produce more. What we're doing is just saying, hey, let's keep it in there longer so that it can get used as much as possible. So we use that for this disease, myasthenia gravis, pyridostigmine. So that's a name you should know. We just said, this is the key teaching point. Why do we want people to take their pyridostigmine 30 minutes before they eat? Right? You want to be able to activate the muscles of chewing. And so taking it 30 minutes before you eat allows time for it to, get in the system and be absorbed and start having its therapeutic effect. And that way they don't end up, choking, having a bolus in their throat and all that stuff. So myasthenia gravis, that is one, just like you have to know, like Parkinson's drugs, you have to know about myasthenia gravis. This is the drug that you use to diagnose. So if you're suspicious that someone has myasthenia gravis, but they could have a bunch of other things, this is the test. And so what we give this drug if they have muscle indirect acting cholinergic. If it improves their muscle strength immediately, then they have myasthenia gravis. It's the same type of indirecting cholinergic drug used as a diagnostic. So there's treatment and diagnosis, and both of these shows up in quizzes and exams. These are all sort of in the same family. They can be used for myasthenia gravis as well. You see they all end in this igmin, pyridostigmine, neostigmine, but they are used to reverse the NMDs. Interesting. Mostly, a lot we use it for, it's available for warfare, toxic agents and stuff. And this is an add-on treatment. Neostigmine might be an add-on treatment. No, pyridostigmine is an add-on treatment. Okay, pyridostigmine is. What do we use first? Oh yeah, I do. But we're not going to talk about it yet. Dementia. So this is the same type of idea. But now we're talking about neurotransmitters in the brain, right? So dementia is this umbrella term. So we have dementia. Dementia doesn't mean Alzheimer's. That is an umbrella. And there are all these types. There's Alzheimer's. There's vascular dementia, there's alcohol-induced dementia, there's Lewy body dementia, there's psychosis dementia. So dementia is the general term. Most people think of Alzheimer's as the same as dementia, and it's not. So when we say Alzheimer's, we're treating a specific type of dementia. Either the drugs were only tested on patients with Alzheimer's and not tested on the other groups, and maybe we experimentally play with people, but most of the tests have been done on this group. So that's why we talk about, okay, these are used in mild to moderate Alzheimer's disease. So early phases when you notice memory losses and misplacing things, and you're starting to really recognize that something's wrong. This is the goal of therapy. What was the goal of therapy in seizure anti-epilepsy meds? Reduction of seizure activity and what?
I improve quality of life.
Yes, same thing here. The goal is to, if possible, stabilize memory loss for a short period of time to maintain quality of life. Super huge problem with these drugs is that they were only studied for 1 year. People get on them and take them forever because there's a lot of fear associated with having dementia. They had very minimal effect when they did have effect. They, on a scale, I think the average, so scale of 0 to 100 of function. Mild to moderate dementia has a functional score, say, of 72. They had, the people who did improve had about a 3-point improvement. So it's not really measurable. And they may or may not have gotten worse, but over time, it's just like heart failure. It's a chronic progressive disease. This is not going to prevent it from progressing. This has only been studied for a year, but because it's a huge drug market, we have an aging population, everybody's so afraid. We have a lot of reasons to have dementia. We have a lot of toxins, toxic air that leads to dementia, vascular disease. So these are the drugs that you should know. They are the basic ones that you get tested on. So donepezil is super, super, super common. And again, we're acting in the brain, right? That's our target organ. It's the exact same mechanism of action, maintaining acetylcholine between neurotransmitters. Drug is mild to moderate. These are the similar mechanisms of action, right? These are just symptoms of any type of dementia, but in specific Alzheimer's. So this is the big key. GI upset is a huge issue in these drugs. People feel nauseous and vomit. So it's something that you have to tell them about. If you have this symptom, you let somebody know, and don't double up if you miss a dose. These are complicated side effects, but the GI is the most common. And obviously, if you're taking a cholinergic medication, what don't you take? Right? You don't take an anticholinergic. You're just, being a moron. They throw this one in the topic of dementia. It's not a cholinergic drug. It's an NMDA receptor agonist that falls into the family like where canopine is. It's probably the only drug out there that's used for the treatment of moderate to severe Alzheimer's. Same goal, same studies, limited effect, limited life of it. It does come in a patch that people like. The trouble is if you have dementia and you put a patch on, kind of common to forget that you have a patch on and put another patch on. Then forget that you have a patch on and put another patch on. And so people who have these terrible side effects, and you do, a physical evaluation of them, and you're like, that patch here, the patch here, the patch here. Okay, that's the worst thing that happens is all people have problems with that 7-day patch of having memory impairment and remembering when to change it. Yeah, it's not a fun one. Yeah, that's just same thing I just mentioned. So we'll end on this today. So when we're talking with patients who have any type of dementia, if they call it Alzheimer's, whatever, call it Alzheimer's. But this again comes up on exams. What's the goal? And what does the nurse need to do is to be realistic about what they can expect, and that all of the drugs are not a cure. If they work, they only work for a short period of time. Yeah. And that therapeutic effects may not occur for up to 6 weeks if they do occur. So those are the 2 teaching ones that you should know. We'll stop here. That was a whole lot of stuff. I am staying after today if anybody wants to like kind of figure out what's the best way to study, how should we organize our thoughts? Do we have questions? I'm just gonna make myself available. You're welcome to hang around if you want, Marissa. Otherwise, I can disconnect. What do you want to do?
We were.